You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is August 25th, 2025. Our topic today is cystic fibrosis. This is presented by Dr. Aaron Kahn, an assistant professor of pediatrics and is the associate program director of the Pediatric Pulmonary Fellowship Program at Children's Mercy Hospital in Kansas City.
Okay, today we are going to talk about cystic fibrosis and talk about highly effective modulator therapies in CF. So we're going to really focus on disease manifestations today. We're going to talk about limitations in newborn screening, and we're going to describe the basics of genetics of CFTR and also talk about the impact on modulator therapy. Feel free to stop me anytime along the way with any questions. I've got a couple little hot tips sprinkled in on this talk, and the first one is this website that is really great for medical professionals. This is through the CF Foundation, which is a really active organization within the CF community. And if you scroll all the way to the bottom of the cff.org website, you'll find this link for medical professionals. So it's really lovely. It has clinical care guidelines there that go through age-specific guidelines, modulator therapy guidelines, diagnosis guidelines, all of the things you could ever want to know. It has some nice information there, so it's a really nice resource for medical professionals. It also is a really nice resource for families as well. So it's meant to be really a family page, but it has some good info for us. So I think we all know cystic fibrosis is a rare autosomal recessive disease. It affects around 40,000 individuals in the United States and around 100,000 worldwide. It's also a hot topic, so there's been some fun things in the media, including this movie a few years ago with some main characters who had cystic fibrosis. It's kind of cute and not entirely accurate. Cystic fibrosis results in a defect of the CFTR protein. And really, to understand what's going on with them, we need to kind of understand that genetics behind it. There are more than 4,000 mutations in CFTR that we know of. And in the past, we've referred to it these sort of classic mutation classes, which we'll talk about a little bit later. But more modern sort of classification is we're going to be talking about sort of functional. So does the protein have any degree of function? So that's really kind of how we break down CFTR. The Cystic Fibrosis Foundation, the CFF, has a lot of good information out there. They put out near annual data reports every couple of years where they sort of update the past year's worth of information for patients. And so the most recent one we have was from 24, but it just came out. So this is 2023 data, but it changes very minimally per year. But you can see here how the prevalence of the most common CFTR variants sort of break down by race and ethnicity. So you can see across the board, Delta F508 is by far the most common, being around 88% of Caucasian individuals, whereas it breaks down a little bit lower for those. But even in that, top 10 mutations, you can see that gets to be pretty rare, with about 1 to 2% of individuals with CF carrying one of those mutations. So we're talking about really ultra rare variants when we sort of get down into those weeds. My next hot tip for you all is cftr2.org. This is a great website that's in collaboration with the CF Foundation, and it breaks down sort of functional classes of different proteins. And so you can see here, you can type in your different variants into CFTR2, and whenever you spit this out, it'll give you results for that specific combination. So when you have two like ultra rare variants, it can give you some really nice clinical information. And so this I just put in, homozygous Delta F508. So you can see here, it breaks it down, what the results of that would be. It gives you clinical information like, is it a CF causing genotype? Does it have varying consequences? Or do we think, nah, this is not going to cause CF classically? And then it also gives you really nice information like, what's the average sweat chloride for those patients? What's their predicted lung function? Should they be pancreatic sufficient versus pancreatic insufficient? Do they, are they more likely to have Pseudomonas? So it sort of gives CF providers really nice clinical information that we can use. So when we're looking at diagnosing cystic fibrosis, you can see here, this is the age at diagnosis for all individuals with CF over the year. And you can see a vast majority of individuals are diagnosed at birth. And that's really because of newborn screening. So newborn screening actually is pretty young for CF. The first state to screen newborn screening for cystic fibrosis was in 1982. Colorado started that, and then it was really quite a while before other states bought into it. By 2004, really less than 10 states. So I think there were 7 states were screening universally for CF on newborn screening, but by 2010, everyone had sort of caught up and everyone was screening on newborn screening in 2010. The last 2 states to join were Texas and Connecticut. So, today in 2025, there are pediatric patients living in some states that were not screened on newborn screening. And so this is one area for how individuals could possibly be missed. And then you can see here, there are a wide range of individuals who are diagnosed later in life. And so you can imagine those older population patients, maybe they just weren't screened on newborn screening, but we might have found them if they were. But there are plenty of patients who are pediatric who were screened on newborn screening, but still missed. So I think it's really important to understand why that might be, especially for, an allergy or an asthma provider who might be seeing patients who have chronic sinus issues, chronic lung issues. And so keeping CF in mind is really important for these patients. So let's talk about newborn screening. Every state starts newborn screening with something called an IRT. That stands for immune reactive trypsinogen. It's actually a marker of pancreatic dysfunction in utero. And so on newborn screening, babies will get the heel stick or a blood draw. And the first sort of stopgap in screening for CF is an IRT. And now it gets kind of confusing because every single state is different in how they screen. And so there's a second tier that depends on whatever that state has decided to do. So most of the states will break down into either repeating newborn screen with a repeat IRT within the first week of life, and then that reflexes into DNA. Or a lot of states, including our, population here in Kansas and Missouri, they will automatically result in doing like a reflex DNA testing on that same sample obtained on the newborn screen. And then if that is positive, they get referred for sweat testing. And again, to make things even more confusing, every state gets to determine sort of what positive means for them. So you can see here, this is just an example of Kansas newborn screening. They actually have a really nice diagnostic algorithm, which I've not really find a lot of other states do. Some states have some nice algorithms, but a lot of states don't. It's kind of confusing and to know what they test for. But you can see here in the Kansas sort of breakdown, again, they screen for an IRT, and if that's elevated, then reflex testing happens. So Kansas breaks it down so their IRT cutoff is 60. There are some other states where that cutoff is totally different. And then they do a CFTR mutation panel. Currently in Kansas, it gets sent out to Wisconsin, where there's over 3,000 mutations that are tested on that panel. So it's a pretty big, comprehensive panel. And then if there are no mutations detected on that panel, it's screened as negative, and so pediatricians will get the report negative newborn screen, even if the IRT was 100 or on the higher realm. Whereas if there were mutations detected, or if it's an ultra high IRT, so if an individual has an IRT value in Kansas that's over 170, even if there's no mutations found, those will get referred to our CF center for sweat testing. And then you can see there how it sort of breaks down. But in our center at Children's Mercy, we hear about all of these patients often before the pediatricians even get the newborn screen report. So we're referring them and giving them in for sweat chloride testing within the first few weeks of life. To make, kind of drive this point home, you can see here is Missouri's newborn screen. So it's not this beautiful algorithm like Kansas has, but it still has some good information. Missouri switched to an IRT DNA model in 2012. So just been, for the last 15 years or so, they've been doing this model, but you can see really depends on the age of the patient. So in that first newborn screen, patients born in the hospital, they get their newborn screen. There's a little cutoff of 55. And so if they're 55 to 59, they actually get referred for a repeat. So they still do this IRT model there. And then if they come back in after 7 days of age and their IRT is 50, that's when they get referred for more testing. And then if it's above 60 on the initial newborn screen, that's when the mutation panel comes into play. Missouri only has 39 mutations that they screen for. They decide what mutations those are, but of course Delta 508 is included, and the most sort of prevalent in our area. Mutations are included in there as well. And then if there's any mutations in there, 1 or 2, that's when they get referred for sweat testing as well. If there's no mutations on there, it gets reported out as negative. Now, our center did some advocacy recently with Missouri newborn screening, and so within the past few years, if there is an ultra high value, that verbiage changed on the newborn screen report, so it still might say like correlate clinically if it's a high IRT with negative mutations, because as you can imagine, those ultra rare kids could easily get missed even if they have CF if they're not one of the 39 mutations. These are the 39 ones that were most recently included. I looked at this within the last few weeks. This was what they test for in Missouri, as you can see there. So to drive this home, I want to talk about a case. So we have a case of a 4-week-old who's presenting after an abnormal Kansas newborn screen. And so you can recall through that algorithm, the baby had an IRT of 101. And so they were reflexed to DNA, and their DNA mutations came back with just 1 mutation. And now this was on the Kansas newborn screen with the 3,000 plus panel. So pretty comprehensive screen there. The kid was referred to our center, had a sweat test that was normal, so under 29 is normal. We see all of these patients and we do some genetic counseling when they come in initially. And so when I was talking to the family, explaining to them about CF, they said, oh, I know, his older brother has inactive CF. And so I had to ask them to elaborate a little bit more on what that meant. So then we actually brought the brother in, and so that he was a 21-month-old male whose initial newborn screening was done in North Carolina. And looking back at his newborn screening, his IRT was 116, and he ended up having 2 DNA mutations on that North Carolina panel. Back then, I went back and looked to figure out, well, what does North Carolina do for their newborn screen? So you can see this was sort of how their breakdown was. They were an IRT DNA model as well. and they initially screened their top 4% of highest IRTs of babies born in a specific time frame, and then were referred to DNA testing. They, at the time that I checked this, screened for about 139 variants, and then they reported this out if the IRT was over 100 and there were multiple variants. That's when they were referred for sweat testing. So based on this, our patient was referred to sweat testing in North Carolina. You might be thinking, like, what about these mutations? Why were they initially thought to have maybe inactive CF or something confusing? So when we plug this specific set into CFTR2, you can see based on the combination that this patient had, says this is a variation of uncertain significance. So we don't really know or have good guidance of what the consequences of this variant combination would be. And so when you look at each one individually, you can see for this specific mutation, 3876del-A, this one is sort of, I call it a backseat driver. So it causes CF when the other variant causes CF, and it causes pancreatic insufficiency when the other variant causes pancreatic insufficiency. So it sort of defaults to the other variant. His other variant was R117H. This one's often in the top 10 for different community populations, and it's one of those sort of variants of uncertain significance where some of the patients who have this will have CF and some of them won't, but most of the patients are pancreatic sufficient. And so you can see with our patient, they were referred for sweat testing, and it was not normal, but it was not diagnostic of CF. It was not greater than 60. They also had stool elastase testing, which looks for pancreatic insufficiency, and it was totally normal, as we would expect based on that combination. So ultimately, looking back at the notes from this initial CF center, they diagnosed this patient with CRMS, and they recommended for them to continue to follow in the CF center, but clearly there was some sort of miscommunication, or the family didn't quite understand what the recommendations were. They moved and then ended up getting lost to follow up. So what's CRMS? CRMS stands for CFTR-related metabolic syndrome. The newer classification, which actually makes a little bit more sense to me, is something called CF-SPID. So CF screen positive inconclusive diagnosis. And so we define CF-SPID or CRMS as a high IRT on that initial newborn screen, just like our patient had. 2 mutations, one of varying significance, like our patient had, but a normal sweat test, which our patient didn't have. Or high IRT plus 0 or 1 mutations with an intermediate sweat. So our patient sort of fell in the middle ground of this. There's also this really nice paper that just came out a year ago that has very good clinical guidelines for patients with CRMS, CF-SPID, and so we use this in our CF center to really care for patients like this that are sort of this gray zone of uncertain diagnoses. This is sort of how it breaks down. So if a kid looks like they have CF, their sweat chloride is greater than 60, that's CF, no question. If they look like they might have CF, but their sweat chloride is normal, then we think of something else. If they don't have any mutations, CF is highly unlikely. Whereas if they have sort of that uncertain significant variant, then that's where CRMS CF-SPID is diagnosed. And then this whole middle ground of patients who have an intermediate sweat, so between 30 and 60, if they have 2 CF causing variants, then absolutely they probably have CF. If they don't, they probably don't. And then there's this sort of middle ground of 1 mutation, CRMS, and then like our patient, where it's kind of like we're not quite sure, there's uncertain significant, then we sort of have this unresolved diagnosis. So for our patient, they came in, the kid's beautifully growing, has no respiratory or sinus symptoms, but had a repeat sweat test that was positive. And so this patient ended up being a new diagnosis of CF around 2 years of age. So you can see how newborn screening is great, but not perfect. Let's talk about disease manifestations of cystic fibrosis. So it really affects you from your nose to your toes. So a lot of different things can happen with CF. You can see that individuals with CF lose salt in their sweat, and so they're at high risk for dehydration. Most patients will have some degree of sinus involvement, and as they get older, it really becomes majority of patients. 25% will have nasal polyps, so lots of overlap that we see there in our allergic community as well. Up to 70% of people with CF will have hepatobiliary disease, so cirrhosis. In pediatrics, this is more rare. There's about 5% or less will have clinically significant liver disease, although this number is increasing a little bit with our treatments that we've had that come with liver toxicity. But classically, this hasn't been as big of an issue for our pediatric population. 85% of the CF community is pancreatic insufficient, so they don't make pancreatic enzymes to digest their food. And then 25% of children will classically develop cystic fibrosis related diabetes, or CFRD. You can see here meconium ileus is common in our infants, so up to 30%. 5% of individuals with CF will develop intestinal problems. So distal intestinal obstructive syndrome is like a true bowel obstruction in individuals with CF. And then rectal prolapse can occur, increasing over time, especially with individuals who have chronic coughing. And then you can see reproductive tract. So there's some infertility that's been classically associated with CF, including congenital absence of the vas deferens in men, and also impaired fertility in women due to mucosal barriers. When we're looking at therapies, where there's a lot of different things that we do for all of these things. So we replace infants and kids and adults with salt. We have antibiotics and nasal cares, or our sinus surgeries that we do for the sinus disease. We have ursodiol or ursodeoxycholic acid for the obstructive biliary disease. We give pancreatic enzyme replacement therapy, or PERT, for pancreatic insufficiency. We supplement all of our kids with vitamins and nutrients to help them grow. Insulin for CFRD. We have bowel regimens and bowel surgeries for individuals with intestinal complications, and assisted fertility for males with vas deferens absence. The mortality from CF is often from the lung disease, and so that's why you're hearing about this from a pulmonologist, because we classically follow CF and treat all of the different disease manifestations. So I like this little infographic here from the CF Foundation that really shows you what's happening on the cell surface layer. So here's the cilia in the lungs, where you can see they're, moving. This is a CFTR protein, and you can see the chlorides flowing freely outside of the cell, but when that doesn't happen, chloride gets stuck. Chloride can't flow out of the cell, and so fluid can't flow out of the cell, and that dehydrates that mucus layer. So you can see that mucus becomes really sticky and thick and makes it really hard for those cilia. Even though they're moving normally, it makes it hard for them to clear that mucus in the lungs. And this sludging can happen everywhere in the body too. Move on. So this is how that sort of manifests in the lungs. So you have an abnormal CF gene. It's decreased either in function or in quantity. So that abnormal surface liquid leads to sort of obstruction of the lungs. This results in progressive loss of lung function. So you can see here, this is information from the CF Foundation again. You can see that over time, as individuals with CF get older, there becomes more lung disease. So this green is saying where, normal lung function or mild obstruction really is kind of normal lung function in our pediatric population, and then it pretty rapidly declines in adulthood, whereas moderate lung disease comes out more and later in life, severe lung disease as well. So this progressive loss of lung function is also complicated by this sort of vicious cycle of obstruction leading to inflammation and infection of that mucus that sits there. And so individuals with CF can get a lot of recurrent infectious concerns. You can see here, this is sort of infectious, the breakdown of different sort of bugs that you can see based on time. So over time, we've seen a decline in Pseudomonas, but we've also, seen this a little bit of rise in Staph aureus, and then a breakdown of other common bugs that we often grow in CF. Here's how it breaks down by age. So in our pediatric population, by far, Staph aureus MSSA is the most common, with Pseudomonas sort of starting in adolescence and growing over time into adulthood. We also see a whole lot more H. flu, just like any other pediatric diagnosis, and so you can see H. flu more commonly in our pediatric group, and then it goes down over time, just kind of like the classic sort of trajectory of that too. And then MRSA in 10 to 20% of the CF community. These matter because we can see increased loss of lung function. We have colonization with certain things, especially with Pseudomonas, especially with things like Cepacia complex or Stenotrophomonas. And so we culture kids who come into clinic every single time to make sure that we're monitoring their microorganisms. This sort of cyclical process of infection leading to more obstruction, leading to more inflammation, ultimately can result in bronchiectasis. And so this is really a very advanced bronchiectasis picture of a patient's chest X-ray and cross-sections of CT scan showing really significant advanced disease burden. This is not what we often see in pediatrics, thankfully, anymore. But obviously, even for a not pulmonologist, you can see something's not right with that imaging, right? And then you see just really thick mucus, plugging, thickening of the airways, and bronchiectasis throughout. That bronchiectasis and this progressive loss of lung function can lead to recurrent pulmonary exacerbations. And so one of the things that we follow really closely in our clinic are pulmonary exacerbations. We don't have a perfect definition of what qualifies of a pulmonary exacerbation. It's kind of one of those, like, when you see it. It's usually an acute worsening or a subacute worsening. And so patients will often have more symptoms like cough, sputum production, dyspnea, hemoptysis, and an acute decline in their lung function. And so we track their FEV1 very closely. If there's any sort of decline, even a 5 to 10% decline, it kind of piques your interest a little bit of what's going on. So we often will require admission for IV antibiotics and aggressive airway clearance in these patients, or sometimes we're just treating them with increased antibiotics or nasal cares or airway clearance at home. But we do see kids and adults still getting admitted for CF. So ultimately, that can then lead to lots of different things. So progressive bronchiectasis and loss of lung function really affects quality of life. This can ultimately lead to respiratory failure, which can result in a couple of different things, which would be either lung transplantation in really adults, or even death. So when we are looking at pulmonary exacerbations over time, luckily, we've seen quite the decline in this, especially in our pediatric population, who was relatively low to begin with. Only about 20% of the community has now dropped down to 10%. And in our adolescents, where we were seeing about 40% coming in with an exacerbation, now we're down, closer to 10 to 15% as well. We're also seeing a huge decline in lung transplantation. So you can see this graph here shows the blue line is adults needing transplant, and the green is children needing transplant. And so right around 2020, we have this sharp decline from exacerbations and lung transplant, and that was all due to highly effective modulator therapy. So highly effective modulator therapy is, I don't think anyone who practices medicine today has not heard of one of these drugs. And so we're going to talk a little bit about modulators and how they've had the effect on our CF community. Earlier, we talked a little bit about mutation classes, and so I really think it's important for us to understand what we're looking at when we're talking about genetics to really understand why modulators have had the impact that they have. So classically in CF, there are these 5 mutation classes. And so normal sort of function of the CFTR is DNA codes for RNA, which codes for protein. That CFTR protein gets folded really nice and beautifully, transported through the cell to the cell surface. It opens up and chloride flows freely, like we saw in that video. In the different mutation classes, different things can happen. In the class 1 mutations, these are stop codons. And so you can see it creates a truncated or shortened protein. So there's no CFTR protein to fold. So there's nothing to transport through the cell. There's nothing to make it to the cell surface. In class 2, which is where delta F508 lies, there's a misfolded protein. So CFTR comes out, it's just processed incorrectly, and the protein is misfolded, and it usually would get broken down in the cell. Whereas class 3, the protein makes it to the cell, but it's a gating mutation. So the gate is closed, and that channel just doesn't open. And so then again, it's sort of dysfunctional, and the chloride can't flow through the cell. Class 3 is a sort of a channelopathy, so a conduction mutation. So the channel opens, it just doesn't work great. And then there's some varying in opinion whether class 5, and there might even be a class 6 out there, but basically it's either doesn't create enough CFTR or it's broken down too quickly. And so this is where the CFTR protein works. It's just not enough quantities of it. So you can see how there's sort of a variety of clinical phenotypes there. When we're looking at modulator therapies, there's 2 different types of drugs that are included in these sort of cocktails. The first type is a potentiator. The potentiator works at the cell membrane. So it works up here in these class 3 and 4 mutations where it helps open the channel. We have 2 current potentiators on the market, ivacaftor and dudivacaftor. The second one that's included in the newer modulators are correctors. And so this goes and helps the protein form correctly. And so you can see here for those class 2 mutations like delta F508, it goes in there and helps refold the protein. There's a couple that we have on the market. You can see 4 listed here. We always use these in combination with the potentiator. And so you can, see how these will work. The first one that came out on the market was in 2012. This was just ivacaftor. Currently, ivacaftor is approved for patients with CF aged 4 months old and up, and you have to have specific mutations. So it has to be either those gating or channelopathy mutations, class 3 and 4, to qualify. And so this really only helped about 10% of the CF population, but the data from 2012 was incredible. So you can see here from that ivacaftor study, patients had a more than 10% sustained increase in their FEV1, which if you remember that sort of graphic, classically we've had just a progressive decline in FEV1 over time. And so for patients with CF to have a 10% increase that sustained over time was truly incredible. You can also see the symptoms were reduced, so less coughing, less mucus, less dyspnea. They decreased their pulmonary exacerbations by 65%, which is also really incredible. And then back in this study, we had about a 6-pound weight increase. That was also really important because we know that individuals who have better BMIs are more likely to have better FEV1s, which are more likely to have better survival. And so you can see here, this is for children, those who have a goal of below 50th percentile. You can see they have a lower lung function, whereas those in the upper percentiles have improved lung function. So really important in kids, but even more so in adults. So this is the sort of graph for men and women and adults, and you can see just a huge difference between sort of that goal BMI for adults who have improved BMI, improved FEV1s. So this was really, really great. But again, only worked for about 10% of the population. So the next that came on the market was called Orkambi. This was a combination of lumacaftor and ivacaftor. And so it was approved initially in 2015. Currently, we have it for 1-year-olds and up, but they must have 2 copies of F508del. So this is for about 30% of our population. The data for Orkambi was not as robust as ivacaftor. So you can see here only about a 3% increase in FEV1. Did still have improved symptoms, did have a decreased pulmonary exacerbation rate, but only a modest BMI improvement. And unfortunately, there was a rather high side effect profile. So a lot of kids ended up not really being able to tolerate Orkambi due to some of the significant side effects. So that springboarded into the next modulator era, which was Symdeko. This included tezacaftor and ivacaftor. First came out in 2018 and currently is approved for ages 6 and up. This tezacaftor sort of expanded coverage a little bit, so it still included those Orkambi kids where there were 2 copies of Delta 508, but also now included individuals who had 1 copy of Delta 508 plus a minimal function, so a class 3, 4, or 5 mutation. So this really expanded, and you can see the data was pretty similar actually to Orkambi, where there was 3 to 4% increase in FEV1, still some improved symptoms, similar reduction in pulmonary exacerbations, no big changes in BMI, but improved side effect profile. So this was a great drug because tezacaftor, ivacaftor became this springboard to Trikafta, which I think everyone has heard of at this point. If they know anything about CF, it's been coined the miracle drug. So Trikafta, or ETI, Alexa Teza Ivacaftor, first came out in 2019, and recently, within the past few years, we have it for patients aged 2 and up. And we also expanded the ability of this for either you have 1 copy of Delta 508 or a minimal function mutation. So this is for about 90% of the CF population, which is very exciting. It's really only those individuals with 2 class 1 mutations who don't qualify for ETI. And then my hot tip is really the best way to sort of tell if an individual is eligible for one or the other is to check sort of their drug website for their eligibility. So you can just type in the mutations there and it'll spit out a report saying yes or no. So Trikafta was similar to ivacaftor kalydeco. So we are seeing this huge 10 to 15% sustained improvement in FEV1. And again, this is for individuals who have the highest disease burden, so like our Delta 508 patients. We are seeing decreased sweat chlorides in these patients, and often their sweat chlorides are going down into that intermediate zone, often below 60. And in a recent study of our 2 to 5-year-old patients, 63% had normalized sweat chlorides in our homozygous delta 508. So now these individuals are having sweat chlorides below 30, which is, I think, truly incredible. We're also seeing much improved symptoms. So that respiratory scores that they were charted during the study had much improvement in their symptoms, and one of the biggest benefits is decreased pulmonary exacerbations. So that's why you saw that big graph of everything sort of dropping off in 2020, was because Trikafta came out in 2019. There's also some downstream effects, and so you can see here, and again in 2019, this is the number of pregnancies in women with CF. And so we saw this spike in individuals who are getting pregnant. So I always counsel all of my teenagers when we're starting Trikafta or any other modulator therapies on them, like, you can't get pregnant. It's with all of our patients about this. The most recent modulator that came out is called Alyftrek, or we call it VTD. So this one was with the new potentiator. This one was just approved in the last year, and we currently have it for ages 6 and up. These patients are similar in that you have to have one copy of F508del or one minimal function, and so it works for about 90% of the population. The biggest benefit of Alyftrek is that it's only dosed once daily. So that's really the only difference between the two. So very similar efficacy for both of them. So we're looking at, changes in FEV1, BMI changes, side effects, all of the things were pretty similar between Alyftrek and Vanza triple, or the Alyftrek is Vanza triple or Trikafta ETI. So kind of just depends on the patient in discussion with the CF team on sort of what we're doing with their modulator therapies at this point. So here's a little summary chart table of our current modulators on the market and when they came out and who they're approved for. And so we're really seeing a lot of kids that are mostly on either Glitaco when they turn 4 months or Combi when they turn a year, and then really almost everyone's transitioning to Trikafta when they turn 2. And then some of our older 6-year-olds are going to be on Alyftrek, depending on sort of the patient and what's specifically going on with them. So back to our case, we have this 21-month-old male who was newly diagnosed with CF. And again, here's the mutations where this class 1 with this sort of backseat driver mutation is a no function mutation, whereas R117H is a class 4. So it's one of those channelopathies. So this patient qualifies for ivacaftor right now until they turn 2, and then can be transitioned to Trikafta if they so choose. And so I always like to sort of pitch this idea to ask you guys, what do you think is the median survival of an individual? This is saying a baby born in 2023. So, a 2-3-year-old right now, what do you think their median predicted survival is? Any guesses? No takers? Yeah, this is 68 years, which isn't that insane. These other numbers are actually like reports from the CF Foundation. They release in their annual register reports, they release predicted survival. And that's based on assuming that no further sort of enhanced medical therapies are discovered. So nothing changes and everything stays exactly as it is right now, then the predicted survival would be 68, which we know there's sort of no one left behind. And one of the CF Foundation slogan is cure found, CF, cure found. And so they're not going to stop until all of our patients, even those other 10%, have some sort of treatment or cure. But you can see in 1993, the median survival was 29 years. So we've more than doubled that just in, some individuals' lifetimes, which is pretty crazy. So I like to think about this. There are brighter futures for our individuals with CF. And so it's really changed the way that we care for individuals with CF. It's changed the way that we counsel babies and families whenever they come in for their initial visit. So you can see, like we talked about over time, the mortality just, really declining. And this is also another little chart that shows sort of mortality per 100,000 people, 100,000 people. But again, right around 2019, we see this sharp decline in mortality. But that doesn't mean that we are done. So in 2023, you can see sort of the cumulative number of deaths. Over 20 people with CF died in that year. And in our population, in our pediatric community, we did see a few deaths in 2023. So we're not done. We are going to continue to work to care for every individual with CF and sort of get this number hopefully down to 0 in our pediatric community. So that is all that I have for you all to talk about CF today. And here is a list of a lot of references and things that we use. And I'm always happy to discuss more if you have any other questions.
Thanks, Dr. Khan. That was fantastic.
Yeah.
I'm going to reflect back. I'm an old man, so I tell stories way too much, and my fellows know that. But I did hospice medicine for about a decade, and of course, we had the bias group because they were the ones that were sick, but the exacerbations were just endlessly numerous. The deaths, unfortunately, were on the relatively high side, and we probably had at least 8 to 12 people in house at any given time here, and all coming in for lots of antibiotics and chest physiotherapy. So, boy, this has changed quite a bit. I'll reflect a little bit also on IRT. It's very parallel to our story with TREX, which are T-cell receptor excision circles that we get. It's a measure of potential T-cell dysfunction and immunodeficiency. And we get a lot of abnormals, or we get some that are kind of in that gray zone that you're going, what to do with it. Requires a bunch more workup. Some of them we can help define they don't have a problem. Some of them do have a problem. And then there's others that, guess we'll just follow them over time. So your IRT sounds a lot like our TREX. Yeah. So anyway, any questions from our listening audience today? Okay. Well, I think one take home for me at least would be keep CF in the back of your mind. If we see a fair amount of sinopulmonary disease here, and even if somebody was born in the era of the new screens, that doesn't mean they're free and clear. So if it kind of looks like CF, it could be CF.
Yes, that's what I wanted to drive home today. So good takeaway.
Yay.
Thank you all so much for having me. Let me know if you need anything at all.
Okay, thanks, Dr. Khan. We appreciate you being here.
Thank you.
Okay, thanks. All right. To the Mercy Fellows, anything we need to chat about?
Not on my end.
Okay.
Can't think of anything.
Okay, very good. I know I owe a few of you emails, a couple related to time off and a couple related to some challenges coming up in clinic. I'll get those things answered likely today. So, all right, guys, have a good week.
Bye.
Thanks, Dr. Miller.
Okay, see y'all.